Good evening. I think all of you are enjoying the awesome sessions. So next will be the must-know topics in respiratory medicine and acid-base balance. So I'll be covering the important algorithms, the treatment protocols, the clinical case scenarios, and what will be the next step in few situations. So these are the list of must-know topics. So no need to write anything. So everything will be provided to you in a video format, and everything will be in a stepwise manner. So these are the topics that I'll be discussing further. So first important is must-know topic in respiratory medicine is spirometry algorithm. So in this spirometry, you must be knowing the algorithm. So first thing what you should see is the FEV1 by FVC ratio. So is it audible, everybody? Yes, is it audible? First you should see the FEV1 by FVC ratio. If it is less, directly you should call it as an obstructive lung disease. If it is normal or increase, it can still be either a normal individual's lung or it can be a restrictive lung disease. So to call it as restrictive lung disease, which parameter further you should see? You should see patient's FVC. So FVC will be less than 80% of predicted. Now in the obstructive lung disease, if it is an obstructive lung disease, the next step here will be bronchodilator reversibility. By giving a bronchodilator, you should see whether FEV1 will increase by more than 12%. Come on students, tell me, if there is a bronchodilator reversibility positive, so it means a reversible airflow limitation. So what is reversible airflow limitation? It is asthma. If there is no significant bronchodilator reversibility, it can be a not reversible airflow limitation, either COPD or bronchiectasis. And you can easily differentiate COPD bronchiectasis based on clinical history. Then if it is restrictive lung disease, is it restriction happening within the lung? Parenchymal restriction where residual volume will be less, or extra parenchymal. So the restriction either due to some chest wall disorders or due to some neuromuscular disorders. So intrinsic restrictive lung disease, the residual volume will be predominantly reduced, such as fibrosis, interstitial lung disease, occupational lung disease. So everything has been discussed in your notes. It is just like a brief revision and to emphasize on important aspects. Then in extrinsic restrictive lung disease, generally residual volume will be maintained. Examples are kyphoscoliosis, neuromuscular disorders, and any diaphragmatic injury. So important point here is the algorithm in spirometry. When do you call it as obstructive? When do you call it as restrictive? And what is classical feature of asthma? What happens in intrinsic restrictive lung diseases? What happens in extrinsic restrictive lung diseases? The next important investigation that you should know is DLCO, diffusion capacity of lung with help of a gas called as carbon monoxide. And this topic you will get straightforward questions. So what are the conditions responsible for decreased DLCO, or what are the conditions responsible for increased DLCO? Decreased DLCO can be seen in severe pneumonia, acute respiratory distress syndrome, fibrosis interstitial lung disease, severe emphysema, anemia, pulmonary hypertension, pulmonary embolism. So regarding pulmonary embolism, frequently they'll ask you a question. So there was an young female clinical scenario based question. Her spirometry values were normal. But DLCO was decreased. And they also mention her hemoglobin is also normal. What might be the probable diagnosis? So normal spirometry with diminished DLCO, one possibility can be pulmonary embolism. So frequently asked clinical scenario with respect to DLCO. Then increased DLCO can happen with polycythemia, exercise, alveolar hemorrhage, and also recently even in asthma we have found out there can be increased DLCO. So mostly there will be straightforward questions and some clinical scenarios as I have mentioned previously. You should know what will decrease DLCO and what are the conditions responsible for increased DLCO. Then the clinical entities, because now the question paper is more clinical oriented, you should know how to differentiate consolidation, pleural effusion, collapse, pneumothorax clinically and also radiologically. So everything is a clinical scenario based. So they might give you a scenario where there is no pull or no push. Okay. So X-ray, there is no tracheal shift and air bronchograms, and clinical history will be decreased movements on right side, decreased movements on right side, dull note on percussion and bronchial breathing. When you find this in combination, X-ray suggests you of some air bronchograms and clinical scenario suggests you of some bronchial breathing. All this should give you a straightforward diagnosis. What is this straightforward diagnosis? It is a right consolidation. Then another scenario, they might give you an X-ray like this where you can see the trachea pushed towards the opposite side. See, disease is appearing on the right because you are able to see a right whitish opacity, and also the mediastinal push can be towards opposite side, and you can see a meniscoid fluid level. And clinical scenario, they mention that movements have been diminished on the right side and you are having a stony dull note right. So disease is on the right and trachea is shifted towards the left. So this is a pushing lesion. So disease is on the right whereas trachea is towards the opposite side. So what can be the possible diagnosis? It can be a right pleural effusion. In the same way, another straightforward question, you can notice a right-sided disease and see here the trachea is completely towards the right and you are not able to see any hard shadow in the left. Everything is pulled towards the right, opacified right hemithorax, and the clinical scenario, breath sounds are absent with shift of trachea towards the same side of the disease. So what might be the clinical scenario that we are talking here? Say pulling lesion and absent breath sounds with right-sided trachea. So it is a right-sided collapse. It is a right-sided collapse. So these are the things that you should know. How to differentiate a consolidation, a pleural effusion, a collapse clinically, radiologically, frequently asked. And then in this X-ray, if you notice, there is a hypertranslucent left hemithorax, and you can see the lung margin getting compressed like this. All this black is actually air. And if you notice, the trachea is more towards right, and heart shadow is also more towards right. It means there is a left-sided disease which is responsible for push of mediastinum. And the clinical scenario, they might mention absent breath sounds. With mediastinal shift to opposite side and hyper-resonant note on percussion. What should be your straightforward diagnosis? This is a left pneumothorax. And in the question, if you identify there is hypotension in the patient, so what might be your diagnosis now? It is a tension pneumothorax. So this compression is causing a life-threatening complication, hypotension. Now what will be the next step in management of a tension pneumothorax? Always next step will be wide bore needle insertion. So this is how you should identify pneumothorax clinically, radiologically, and this is a medical emergency. and next step will be an intervention to save the life of the patient. Then the respiratory failures, you must be knowing the types. Type 1 is called as hypoxemic respiratory failure, generally due to decreased transfer of oxygen. Type 2 is a hypercapnic respiratory failure due to decreased respiratory effort or hypoventilation. And type 3, it generally happens because of general anesthesia post-operative due to lung atelectasis. Type 4, shock-related respiratory failure due to decreased cardiac output and hypoperfusion. So for all clinical purposes, commonly what we see is type 1 and type 2 respiratory failure. And you should know the common causes of type 1 respiratory failure. It can happen in severe pneumonia, type 1 respiratory failure. In severe pneumonia, ARDS, see everything is discussed in your class notes. So all this I'm focusing on what you should not forget. ILD, pulmonary embolism. These are the conditions generally associated with type 1 respiratory failure. Whereas type 2 respiratory failure, you know a mnemonic called as COPD. C for central causes such as brainstem injury, central causes, brainstem injury, narcotic use, O for some obstruction within the airway, such as a large foreign body, especially in the trachea, severe COPD. P for peripheral causes happening over the chest wall, such as neuromuscular disorders. And D for strongest respiratory muscle is your diaphragm. Any diaphragmatic injury. So in a clinical scenario, you should check whether patient is having any of these factors responsible for respiratory failure, and by seeing patients PaO2 and PaCO2, you should be able to identify whether it is a type 1 respiratory failure or type 2 respiratory failure. And coming to the ultimate treatments, mechanical ventilation. So this is invasive mechanical ventilation. So generally preferred type for type 1 respiratory failure. Whereas in this image, you are giving the ventilation with help of a face mask. So this is NIV. It is preferred in type 2 respiratory failure, especially the severe COPD. So this also you should know. When patient with respiratory failure is not getting improved by conventional management, if it is type 1 respiratory failure, we generally go for invasive mechanical ventilation. If it is type 2 respiratory failure, especially severe COPD, we first try with non-invasive ventilation. If patient not improving, then we can go for an invasive mechanical ventilation. Then in ARDS, acute respiratory distress syndrome, the criteria are important. The first is acute onset of dyspnea within 1 week and bilateral opacities on a chest X-ray. So you are unable to explain it with effusions. They are not effusions. It is not collapse. It is not nodules. So bilateral diffuse infiltrates. Origin of edema is non-cardiogenic. And if you see the PaO2 by FiO2 ratio, it will be less than 300 mmHg. You must be able to identify in a given clinical scenario, is this patient in ARDS? So what are the points? Acute onset of dyspnea, bilateral chest infiltrates, then origin of edema, non-cardiogenic, PaO2 by FiO2 ratio less than 300. ARDS is generally a very, very dangerous complication. Ultimately, patient requires mechanical ventilation. And in this COVID scenario, because COVID ultimately lands up in a patient to ARDS, you should know the ARDS ventilation protocol as discussed in the class. So start treating the underlying cause, and most beneficial or recommended in ARDS mechanical ventilation is low tidal volume mechanical ventilation. Low tidal volume mechanical ventilation. So it means we should give 4 to 6 ml per kg body weight. 4 to 6 ml per kg body weight. Then not only the volume should be kept at low, even the pressure, it should be kept less than 30 centimeter H2O. This flat tube pressure is pressure given to the smaller airways. It can be seen on the ventilator monitor. So make sure the pressure is not high, the volume is not high. So why is it so? To avoid ventilator associated lung injury. So high PEEP, positive end expiratory pressure, to open the alveoli and facilitate oxygenation. Then give some sedation and neuromuscular blockades to completely knock down the patient and facilitate ventilation. And glucocorticoids may be beneficial, and like any other critically ill patient, take care of the fluid and electrolyte balance. You must know how to identify a patient in ARDS, and if it is ARDS, these are the things that you should keep in your mind when you have connected him to a mechanical ventilator. And you should know the rescue therapies in severe ARDS. We have extracorporeal membrane oxygenation and the very famous prone ventilation. So when the patient is not improving with conventional mechanical ventilation, if ECMO is available, you can go for ECMO or you can do prone ventilation. So all these are beneficial, especially in severe ARDS. So beneficial, especially in severe ARDS. The next topic is pulmonary thromboembolism. You must be knowing in pulmonary thromboembolism the investigations. So investigation of choice for pulmonary thromboembolism is always CT pulmonary angiography. Investigation of choice is CT pulmonary angiography. Whereas a screening test, it has become famous again in this COVID pandemic, it is D-dimer. D-dimer is not confirmatory test for pulmonary thromboembolism. And the confirmatory test is generally the CT pulmonary angiography. Now you have identified a patient suspicious of pulmonary thromboembolism. Now how will you plan the treatment protocol? So they will ask you, this is a case of these symptoms suggestive of pulmonary thromboembolism. Now what will be your most appropriate next step? So for this you should know the algorithm. Are you dealing with a massive pulmonary embolism, a submassive pulmonary embolism, or a minimal pulmonary embolism? Massive means a very big thrombus obstructing the right ventricle. Because of that, your right ventricle is not pumping properly. Ultimately, blood pressure has decreased. So in massive PE, the important feature is patient will be in hypotension. Pulmonary thromboembolism clinical scenario with hypotension, most probably it is massive pulmonary embolism. So you should stabilize the patient's BP by giving IV fluids, vasopressor, and you should start anticoagulation. And if they ask you what is definitive treatment, there is a big thrombus occluding the pulmonary artery. What you should do? You should break that thrombus. So in majority, the preferred is thrombolysis. So in few, there might be contraindications for thrombolysis such as coagulopathy, some recent trauma, or previous history of some intracranial hemorrhage. In those patients, I cannot give thrombolysis. I generally go for surgical embolectomy. But it will be very, very rare situation. So 1 in 1000 or 1 in 10,000 patients. Whereas submassive, anticoagulation, monitor the patient closely. And if there is any hemodynamic compromise, then only you should go for thrombolysis. Whereas minimal pulmonary embolism, a small thrombus, anticoagulation will be sufficient. So here must know concept is how do you identify massive pulmonary thromboembolism and what will be the appropriate therapy. So the blood pressure is important and appropriate therapy will be thrombolysis ultimately. Then pneumonias. So the classification based on site of occurrence: community acquired pneumonia, nosocomial pneumonia. So this is the recent classification given by European Respiratory Society. Community acquired pneumonia happening outside in community settings. Hospital acquired pneumonia 48 hours after hospitalization. So you should know this time frame. Ventilator associated pneumonia 48 hours after invasive mechanical ventilation. And the common causes: is it typical pattern, atypical pattern of community acquired pneumonia? Typical means the routine pattern. So patient presents with fever, productive cough. So patient will have fever and productive cough. So that is typical. Atypical means fever plus dry cough. So this will be given in the clinical scenario, and accordingly you should identify the organism. And in typical pattern, most common is streptococcus. Atypical pattern, most common will be mycoplasma. So again, it is clinical scenario based. So depending upon patient's symptoms: fever, productive cough typical, fever, dry cough atypical. And in hospital acquired, most common will be gram-negative rods. And ventilator associated, early VAP, late VAP. Early VAP, most common streptococcus. Late VAP and VAP overall Pseudomonas. So VAP overall Pseudomonas. So this is the important classification of pneumonia. So based on the site of occurrence. Now let us see some common pneumonias based on the clinical scenario. So they might mention patient is having red currant jelly sputum. And what do you see on chest X-ray? So chest X-ray, it is showing bulging fissure sign, right upper lobe consolidation, bulging fissure sign. So it is Klebsiella pneumonia. So all this is suggestive of Klebsiella pneumonia. Then a patient with red rusty sputum is having pneumonia, and this was the chest X-ray. So chest X-ray is suggestive of lobar consolidation. So lobar consolidation, what can be the organism? It is most commonly streptococcal pneumonia. Another patient, chest X-ray showing cavity with air fluid level, and patient is a known alcoholic. So frequent history of aspiration, and he is having foul smelling sputum. Now what might be this entity we are discussing? So it can be a primary lung abscess. So why it is primary lung abscess? Because it is due to aspiration. So what will be the next step in management of a primary lung abscess? We have to administer clindamycin to this patient. So this is a primary lung abscess. So lung abscess, so if it is due to aspiration, they are called as primary lung abscess. And most common organism will be those residing in the oral cavity, oral anaerobes. So treatment is clindamycin. Secondary lung abscess, it is due to some pre-existing lung disease getting complicated. Organisms such as Staph aureus, Pseudomonas, and according to the organism you can give. Then assessment of severity of pneumonia. So it is by the curve 65. So the components: confusion, blooduria, respiratory rate more than 30, blood pressure, either systolic BP less than 90 or diastolic BP less than 60, age more than 65. So for each parameter we are going to give 1 point, and we are going to see total score in a patient with suspected pneumonia. If his score is low, 0, 1, so patient can be managed at home. If his score is 2, definitely hospital admission. So if the patient score is 3 to 5, so consider it as severe pneumonia. Patient may require ICU admission. So you should know where to treat the patient with pneumonia according to the curve 65 score. So when to treat at home, when to treat in hospital ward, and when patient might require ICU admission. Now, in this COVID pandemic, what is the causative agent? It is SARS-CoV-2 virus. And what is the disease it is causing? It is COVID-19. So SARS-CoV-2 is the name of the virus. So just like disease is malaria, the causative agent is Plasmodium, disease is COVID-19, the causative agent is SARS-CoV-2. Now what are the tests available for diagnosis? So gold standard. So if they ask you what is gold standard, the gold standard will be RT-PCR. The gold standard will be RT-PCR, and the result you get within 4 to 6 hours. Whereas Indian technology, TrueNAT, result 1 to 2 hours. And rapid antigen kits result you can get within 15 to 20 minutes. And for all this, preferred sample is a nasal swab or throat swab. So nasal swab or throat swab. And there is also a new test not yet approved for official use by government. So it is called as FELUDA. FELUDA is FNCAS 9 editor linked uniform detection assay. So it is based on gene editing technology. It is not yet into the official guidelines of our country. So in the official guidelines, we have RT-PCR, TrueNAT and rapid antigen kits. And in COVID-19, what are the parameters that can be elevated? So there can be mild leukocytosis, lymphocytes will be low. Because of ongoing tissue damage and hyperinflammatory response, inflammatory markers such as CRP, ferritin, LDH, due to myocardial injury, troponin, due to liver injury, AST, ALT, and due to muscle injury, creatinine kinase can be elevated. Because of the thrombotic complications, even D-dimer will be elevated. Even D-dimer will be elevated. And very important question, out of all this, which has some significance in mortality? High D-dimer levels and more severe lymphopenia have been associated with mortality. So if you find patients with very high D-dimer levels and more severe lymphopenia, so more chances of mortality. Now coming to the treatment protocol, COVID-19 patient, very important. You should know when to call it as mild, when to call it as moderate, when to call it as severe, when to admit the patient and what to administer to the patient. So mild means patient will be having fever without features of upper respiratory tract infection. Moderate, so pneumonia features, SpO2 less than 94 and respiratory rate will be more than or equal to 24. So from moderate onwards, patient should be admitted. So patient requires admission. Whereas severe, respiratory distress requiring mechanical ventilation, SpO2 will be less than 90%, respiratory rate will be more than 30 per minute. So in mild cases, generally isolation, symptomatic care and hydroxychloroquine may need to be given in high-risk patients. So high-risk patient in the sense, age is more than 60, patient is having some comorbidities. Whereas moderate patient, he requires admission in COVID care unit. Oxygen prone position is important. Out of all the drugs, steroid is the only drug which is known to decrease mortality. So previously asked question. So which is the drug known to decrease mortality in a COVID patient? Your answer should be steroid. So steroid is the only drug which is known to decrease mortality in a patient with COVID. So along with that, anticoagulation, and you may consider remdesivir, convalescent plasma also. So when the patient becomes sick, he requires ICU admission. So within the ICU, we can initially start high flow nasal cannula or non-invasive ventilation. Again, proning, steroids are very important, anticoagulation given. And you can consider remdesivir and if required, anti-IL-6. Anti-IL-6 that we have is tocilizumab. So it will fight against the hyperinflammatory response. If at all patient is having absent breathing, severe respiratory distress, central cyanosis, you may need to start invasive mechanical ventilation, and you should ventilate according to ARDS protocol. So this is regarding COVID-19 treatment. And other important drugs, vitamin C, vitamin D, zinc can be given, and doxycycline, ivermectin, favipiravir can be given. But this doxycycline, ivermectin, favipiravir are not included in the Indian guidelines. Then approach to pleural effusion. Depending on the Light's criteria, you should be able to make out whether it is a transudative effusion or a exudative effusion. So if it is a transudative effusion, look for systemic cause. Is there any heart disease? Is there any kidney disease? Is there any liver disease? If it is exudative cause, you may need to further test the pleural fluid. So cytology to look for any malignancy, and gram staining to look for any infection and to see what is the type of cell elevated. And TB markers, ADA, interferon gamma can be elevated. Low glucose pleural effusion can be seen in empyema, malignancy, rheumatoid arthritis related pleural effusion. Increased amylase pleural effusion in pancreatitis, esophageal rupture, malignancy, and increased triglycerides can be seen in chylothorax, and increased cholesterol effusion can be seen in pseudocylothorax. So this is an algorithm which will tell you how to evaluate a pleural effusion. So based on Light's criteria, transudate, exudate. If it is transudate, look for systemic cause. If it is exudate, you need to do further testing to find out the reason. Then in asthma, important will be the XENA guidelines. So in XENA guidelines, let it be at any step, if patient develops acute symptoms, you need to give rescue medication. So rescue medication right now is low dose inhaled corticosteroid with formoterol. And maintenance therapy, step 1 is intermittent asthma, so rescue medication sufficient. Whereas from step 2 onwards, you must give some regular maintenance therapy. So here, step 2, we give low dose inhaled corticosteroid. Step 3, low dose inhaled corticosteroid plus LABA. Step 4, medium dose inhaled corticosteroid plus LABA. Step 5, high dose inhaled corticosteroid plus LABA. So these are the drugs given at various steps. And add-on therapy, so step 2, we can add anti-leukotrienes. So step 3 also, we can give anti-leukotrienes such as montelukast. Whereas step 4, add-on therapy, anti-leukotrienes plus tiotropium. Whereas step 5, we can give tiotropium plus oral steroid. So these are all the XENA 2020 guidelines. So maybe after April, after your exam, there will be 2021 guidelines. So if patient develops acute symptoms, now the rescue medication is low dose inhaled corticosteroid with formoterol. Then coming to COPD. So COPD Gold 2020, depending upon patient symptoms and exacerbation history, we are classifying the patients into 4 categories: Group A, Group B, Group C, Group D. So Group A, less symptoms, more symptoms. Less exacerbations, more exacerbations. Less exacerbations and more exacerbations, depending upon the exacerbations that has happened last year and depending upon patient symptoms. So symptoms can be graded based on MMRC scale. So Group A, single bronchodilator will be sufficient. Group B, definitely a long-acting bronchodilator. Group C, you should go for the most effective bronchodilator, long-acting muscarinic antagonist. Group D, you can start with LAMA. If persistent symptoms, patient should be changed to LAMA plus LABA. If patient is having history of asthma, you should go with LABA plus ICS. So this is the gold 2020 guidelines that you should know. So depending upon patient symptoms and exacerbation history, so we have classified the patients into 4 groups: Group A, Group B, Group C and Group D. Then bronchiectasis, you must know how to identify the patient with bronchiectasis. History will be chronic productive cough and crepitations. And CT chest, there will be this dilated airways. So what are these dilated airways appearance called as? It is called as tram track appearance. So it is called as tram track appearance. An investigation of choice in bronchiectasis is an HRCT chest. And what do you see? It is tram track appearance. Then aspergillus and lung. So there are various manifestations. I'll give you the clinical scenario with radiological findings. There can be central bronchiectasis and the case summary will be poorly controlled asthma, elevated IgE and central bronchiectasis. Now what is this aspergillus related lung disease? It is allergic bronchopulmonary aspergillosis and treatment is steroids. And then another patient, organ transplant, means immunocompromised, history of fever, shortness of breath, hemoptysis. With such a CT chest finding, what do you see? CT halo sign. What is this? Invasive pulmonary aspergillosis. And treatment here will be oriconazole. Another patient, known case of pulmonary TB, completed treatment, routine chest X-ray taken, and chest X-ray is showing cavity filled with fungus, monad's sign, and treatment is generally resection. And what can be the diagnosis here? It can be an aspergilloma. Then in ILD, you must be knowing the differences between 2 common types. Now tell me, what is this? On CT chest, traction bronchiectasis, honeycombing. Clinically, patient is having chronic symptoms, restrictive pattern on spirometry, bilateral honeycombing, and his biopsy is showing fibroblastic foci. So what is this type of ILD? It is UIP, usual interstitial pneumonia. If you are unable to find out the cause, it is called IPF. So treatment will be pirfenidone nintedanib. Whereas another ILD pattern, subacute symptoms, restrictive pattern and bilateral ground glass opacities. So what can be this? NSIP. So non-specific interstitial pneumonia, you see it is only ground glass opacities. Whereas UIP, you can notice this honeycombing. And the treatment here will be a steroid. Then the differences between various occupational lung diseases, asbestosis and silicosis. Asbestosis characterized by pleural plaques, pleural effusions, and it is predominantly lower zone. Most common malignancy is adenocarcinoma. Most specific will be mesothelioma. Round atelectasis can happen. Silicosis, upper zone nodules, progressive massive fibrosis, lung cancer can happen, and silicosis prone to tuberculosis. And you can see bilateral hilar lymph node enlargement with eggshell calcification. So these are the differentiation. So asbestosis, mostly lower zone predominant disease. Silicosis, upper zone. They can give you a clinical history. So according to that, you should find out whether it is asbestos-like or silicosis-like. And obstructive sleep apnea. So on the polysomnography, you can notice apnea, no airflow, but respiratory effort is present. Gold standard is polysomnography. And the case summary, patient will be obese, complaining of snoring and obstructive events. All these are suggestive of obstructive sleep apnea. And for diagnosis, polysomnography. And the categorization, mild. AHI means apnea hypapnea index. So how many times in an hour patient is getting apneas and hypapneas? So if they are less, it is mild. Significant, 15 to 29, moderate obstructive sleep apnea. More than or equal to 30, severe. And medical management of choice will be, especially for moderate to severe, it is CPAP, continuous positive airway pressure. Then in malignancy, you should know the paraneoplastic syndromes. Small means less, hypo means also less. So all hypos generally associated with small, hyponatremia, hypokalemia, hypocalcemia, whereas squamous cell, hypercalcemia. Adeno, you can notice hematological paraneoplastic syndromes, and these they will give you as pictures. Patient is having these manifestations and lung cancer. What might be the histology? What do you notice? Migratory venous thrombophlebitis, also called as Troche syndrome, clubbing. So this is suggestive of adenocarcinoma. And what do you notice here? Ptosis. Ptosis with lung cancer. It can be Horner syndrome due to tumors of lung apex, Pancoast tumor. And what do you see here? Neck swelling, dilated veins over chest wall. All this is suggestive of SVC obstruction. And SVC obstruction most common with small cell lung cancer. Now this combination, a tumor in the lung apex. So one tumor of the lung apex and destruction of first two ribs can happen, and involvement of C8, T1, T2. So the nerve roots C8, T1, T2 resulting in pain along ulnar distribution and also weakness, and also Horner syndrome. So there is a tumor in the lung apex, Pancoast tumor causing all these manifestations. All these manifestations put together, it is called as a Pancoast syndrome. So they might mention there is a patient with lung cancer with these manifestations. So what is your diagnosis? Your diagnosis should be Pancoast syndrome. Then the TB regimens, drug sensitive TB, new case or previously treated, it is a single regimen 2 HRZE plus 4 HRE. Isoniazid resistant TB, 6 months of levofloxacin, rifampicin, pyrazinamide, ethambutol. MDR TB, rifampicin resistant TB. So the regimen duration is 18 to 20 months. And the drugs are bedaquiline, levofloxacin, linezolid, clofazimine, cycloserine. And bedaquiline generally stopped after first 6 months. XDR TB is also the same regimen, but treatment should be given for 20 months. So again the same drugs, bedaquiline, levofloxacin, linezolid, clofazimine, cycloserine. So whereas for MDR TB there is also a shorter regimen if there are no contraindications. So this shorter regimen is for 9 to 11 months. 9 to 11 months. So initial 4 to 6 months, high dose isoniazid, pyrazinamide, ethambutol, kanamycin, moxifloxacin. So this ETO means ethionamide, and along with that clofazimine. For next 5 months, pyrazinamide, ethambutol, moxifloxacin, clofazimine. So in a single slide, I have covered all the regimens of the National Tuberculosis Elimination Program 2020. So apart from this, whatever regimen you see, they are all old regimens. Then ABG interpretation, you should know how to identify whether it is respiratory acidosis or alkalosis. So here change in pH with respect to parameters will be in opposite direction. If it is metabolic, change in pH with respect to parameters, it will be in same direction. So after knowing whether it is respiratory or metabolic, you should calculate the compensation and then anion gap to categorize it into high or normal anion gap metabolic acidosis. So high anion gap, ketoacidosis, lactic acidosis, renal failure, toxins. So toxins such as methanol, ethylene glycol, paraldehyde poisoning, salicylate intoxication. Normal anion gap we have due to pancreatic fistula, ureterosigmoidostomy, diarrhea, carbonic anhydrase inhibitor, aldosterone deficiency, and renal tubular acidosis. So why metabolic acidosis happens here? Why anion gap? Why normal anion gap? All is discussed in your regular classes. So this is just must know session. You should know these conditions responsible for normal or high anion gap metabolic acidosis. Then in metabolic alkalosis, saline responsive, saline unresponsive. Saline responsive generally associated with volume loss, vomiting, Rayleigh tube aspiration, diuretic use. Saline unresponsive, we have primary aldosteronism, Cushing syndrome, renin secreting tumor, Bartter syndrome, Gitelman syndrome, Liddle syndrome. So these are all the must know topics, about 18 topics in respiratory medicine. So, and I have given a brief gist about each and every topic. So thank you for your patient listening. Students, all the videos will be uploaded. Any doubts, you can tag me on Facebook. Thank you, students. All the very best.